Hey everyone, welcome to today's Explainer. I am so incredibly pumped you're here. Today, we are going to teach you the exact, precise clinical criteria for some seriously profound and honestly highly misunderstood psychological conditions. If you're a focused learner, looking to master the real diagnostic parameters of severe distress without all the fluff, you are in exactly the right place. By the time we wrap up, you'll have a rock-solid clinical understanding drawn straight from the diagnostic sources.
All right, here's our roadmap for today. We'll start with the anatomy of panic disorder, followed by its origins and treatments. Then we're going to decode binge eating disorder, hit its origins and treatments, and finally wrap up with a high-speed diagnostic lightning round.
Section 1. Anatomy of panic disorder.
Okay, let's dive into this. A panic attack isn't just, feeling super stressed out or overwhelmed by a bad day at work. Clinically speaking, it's an abrupt surge of intense fear that peaks within minutes, accompanied with severe physical symptoms. Think of it like a physiological tidal wave. It hits fast, it peaks incredibly quickly, and the physical reality of it is just completely overwhelming for the person going through it.
To really understand what that tidal wave feels like, we've got to look at the striking physical symptoms. We're talking heart palpitations, heavy sweating, and literally uncontrollable trembling. Patients experience profound shortness of breath or even a choking sensation, paired with chest pain and nausea. Plus, there's often dizziness and this terrifying symptom called derealization, where the whole world around them suddenly feels unreal or distorted. When you look at the whole shebang, it absolutely validates why patients feel like they're literally dying or losing their minds. Their body is sounding a massive 5-alarm emergency siren. Now here's where we need to be really precise. Having a panic attack does not automatically mean you have panic disorder. The clinical distinction is that a diagnosis requires at least one attack, right? But then it has to be followed by a month or more of persistent worry about having another attack, or making huge maladaptive changes in behavior, like refusing to go to the grocery store just to avoid triggering one. So the disorder is fundamentally about that lingering, life-altering dread of the next attack.
And that lingering dread brings us right to agoraphobia. Clinically, this is the fear or avoidance of situations where escape might be difficult if those panic symptoms suddenly popped up. While agoraphobia is coded as a separate diagnosis, it very frequently co-occurs with panic disorder, and it makes total sense, right? If your body unpredictably hits you with those terrifying symptoms we just talked about, of course you'd be terrified of being trapped in a crowd or on a bridge when that internal alarm goes off.
Section 2. Panic origins and treatments.
So where does this come from? Well, the origins are multidimensional. On the biological side, we're looking at a heightened sensitivity in the brain's amygdala, fear network. There's also a genetic panic proneness and literally a hardware misfire of the body's suffocation alarm system. It's wild. Psychologically, it's driven by anxiety sensitivity and the catastrophic misinterpretation of completely normal body sensations, which is also known as interoceptive conditioning. And socially, usually a highly stressful life event acts as the initial trigger, setting this whole cycle into motion.
So how do we fix it? One of the most fascinating treatments in cognitive behavioral therapy is called interoceptive exposure. This is where the therapist and patient work together to deliberately induce the specific bodily sensations the patient fears most. If they're terrified of dizziness, the therapist might literally have them spin in a chair. Fearing a racing heart? Time to run in place. It sounds totally counterintuitive, but it's an absolute game changer.
Now I want you to think about this for a second. Why on earth would a clinician purposefully trigger the exact physical sensations a panic patient fears the most? It sounds almost cruel, right? But here is the therapeutic genius of it. It's the absolute key to cognitive restructuring. By inducing a racing heart or shortness of breath in a super safe, controlled environment, the patient learns that these sensations are just physical feelings. It's not a heart attack, it's not suffocation. It actively breaks those catastrophic thinking patterns. Alongside CBT, there's also the pharmacological route, and we need to teach a really clear distinction here. SSRIs, selective serotonin reuptake inhibitors, those are for everyday long-term management to lower that overall baseline anxiety. Benzodiazepines, on the other hand, are strictly for short-term or acute relief. They work super fast to stop an active panic attack in its tracks, but they aren't the primary tool for long-term structural recovery.
Moving on to Section 3. Decoding binge eating disorder.
All right, so binge eating disorder, or BED. This is characterized by recurrent binge eating episodes, where a person eats rapidly way past the point of comfortable fullness. A huge defining hallmark here is this profound feeling of a complete loss of control.
These episodes almost always happen alone because the person feels severe embarrassment about the quantity of food being eaten. And immediately after, they're just intense, heavy feelings of guilt and self-disgust.
To actually meet the clinical threshold for a diagnosis, these episodes have to happen at least once a week for 3 months. It's also deeply tied to marked emotional distress about the binges themselves. And here's something absolutely crucial I want to teach you. We have to dispel the myth that BED is strictly tied to weight. Yes, it's often associated with being overweight or obese, but definitely not always. The core clinical feature is the behavioral pattern and the emotional distress, not the number on the scale.
So what's the difference between binge eating disorder and bulimia? The absolute key differentiator is the absence of regular compensatory behaviors in BED. In bulimia, a binge is followed by compensatory actions, right? Like purging or excessive fasting. But in binge eating disorder, the binge happens, the intense guilt follows, but those regular compensatory behaviors are clinically absent.
Section 4. Bed origins and treatments.
When we look at the origins of BED, it's really this heartbreaking collision between the internal and the external. Psychologically, binge eating is often used as a maladaptive tool for emotion regulation, basically a way to cope with negative feelings or emotional pain. It's also heavily tied to a personal history of dieting. But then, look at the social and socio-cultural side. You see how weight stigma and its pervasive dieting culture just pour fuel on the fire, worsening the shame and driving that nasty cycle of restriction and loss of control.
But there is good news. We have proven clinical treatments. On the psychological side, cognitive behavioral therapy is highly effective. Same goes for interpersonal psychotherapy, which focuses on improving the relationships and communication patterns that might actually be triggering all that emotional distress. And medically, lisdexamfetamine is explicitly FDA approved to treat BED, giving us a really vital biological tool to help regulate those binge urges.
All right, grab your notebooks and let's amp up the energy. Section 5, the diagnostic lightning round.
We want to teach you exactly how to differentiate between highly similar disorders for your exams or clinical practice. First up, anorexia versus bulimia. The absolute key distinction here comes down to weight status and specific compensatory cycles. Both feature a distorted body image and this intense fear of gaining weight, sure, but they present entirely differently when you look at the objective number on the scale versus the specific cyclical behaviors the person engages in to control it.
Next up, how do you tell somatic symptom disorder, illness anxiety disorder, and conversion disorder apart? Well, here is the perfect mnemonic. Categorize them by their core focus. Somatic symptom disorder is symptom-focused. There's real distress about actual physical symptoms. Illness anxiety disorder is worry-focused. The distress is all about the idea or fear of having a disease, without significant physical symptoms. And conversion disorder, strictly neurological-focused. We're talking blindness, paralysis, things like that, without a medical cause. Master those distinctions and you'll literally never confuse them again.
Finally, I want to leave you with a really profound, provocative question to ponder as we close out today's explainer. How does dissociation act as a trauma defense mechanism across the dissociative disorders? We've spent today talking about bodies sounding false alarms and minds struggling to regulate emotions. But when we look at dissociation, we're looking at the brain's incredible, complex ability to literally disconnect from reality just to survive extreme, overwhelming trauma. It's a stunning protective mechanism that challenges everything we know about human resilience. Thank you so much for learning with me today, and keep exploring these fascinating frontiers of the mind.